This is our discussion portion of the interview here today. First question that's come in is, are these panels more accurate than coronary artery calcium scores, and what are the reasons I should use these multi-protein scored panels versus a coronary artery calcium score, which is less expensive? And then they gave an example here. A more accurate HART, H-A-R-T, is $199 per test. 2 tests for $328. Second is $129 if ordered at the first test, or calcium score is between 99 and 149. That question is throwing a lot at you.
Yeah, no, it's okay though, because I've already sort of addressed some of this. Calcium scoring is a great test. I mean, there's no question that particularly for, just like the heart blood test, if your CAC is 0, if you have a calcium score of 0, that's where the money is with calcium scoring. The problem with calcium scoring is that anything above 0, we're immediately in an ambiguous situation where we don't know whether there's obstructive coronary disease. B, we don't know if there's lipid-rich coronary disease. All we know is there's calcium. And that's a challenge, particularly when we're trying to decide on, among other things, what's the risk of my patient and what should I do medically. And for anyone that says, well, I already know what to do medically for patients that are at higher risk, I would challenge even my best colleagues at Mass General Hospital to take a step back with humility and look at how we are managing our patients. We are doing a good job. We're doing a better job at lipid lowering. It looks, there were recent statistics showing, for example, that 58% of individuals that were eligible for statins in the United States are now receiving them, which is a lot better than it was, say, 10 years ago. But that means 42% aren't receiving it, number one. Number two, it also means that the highest risk patients are very likely the ones that we're missing. Right. And to the extent that we know that almost every therapy we give has an incremental benefit in the higher risk folks, but you need to know how to titrate these therapies. A CAC score isn't going to tell you your patient is at risk for high risk for a myocardial infarction in 1 year, nor is it going to tell you they've got lipid-rich plaque, nor is it going to tell you that they've got highly obstructive disease like these 2 blood tests do. So it allows me to make informed decisions about the need for lipid lowering, the intensity of lipid lowering, the need for other therapies like direct treatment for atherosclerosis or coronary ischemia, and whether or not I need to go to further testing. The use of CAC scoring, is helpful to maybe, reclassify people to a very low risk strata, but anything other than that, I'm not sure that there's a really good comparison here.